Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm an associate professor of medicine in the Division of Hematology Oncology, and I'm coming to you live from ASCO GI 2018 in San Francisco for this Velocity Vlog program entitled Management of Hepatocellular Carcinoma, Putting Tyrosine Kinase Inhibitors in the Spotlight. Thank you for joining me. The management of liver cancer has been changing over the past few years. It's a very exciting time for us and patients given the multiple positive phase 3 studies that we've been seeing results of in the past several months. As you're aware, liver cancer is a very difficult disease to treat. Part of the reason for that is that it is really two diseases. It's not only a malignancy, but it's also chronic liver disease. 90% of our patients have some degree of cirrhosis. And when a malignancy occurs in the liver, our approach to managing these patients really takes into account both their underlying liver disease as well as tumor characteristics. The focus of today's program will be on the use of tyrosine kinase inhibitors in the management of liver cancer. When we're talking about the use of these agents, the first thing we need to do is really identify who are the appropriate patients for systemic treatment. Liver cancer often occurs in the background of a sick liver, and sometimes it is caught in screening programs. Other times it's caught when it's fairly advanced and symptomatic. For patients who are found with disease confined to the liver, who have well-compensated liver disease, then clearly there's a role for potentially curative therapy, such as surgical resection, or in some cases radiofrequency ablation. For patients who have underlying cirrhosis, liver transplant is an option. For patients who are not going to get a curative treatment immediately, other local regional therapies such as chemoembolization play a key role in managing the disease and extending survival. But it's important to remember that these approaches, while they can extend survival in appropriate selected patients, are not curative, and that eventually a patient will develop some characteristic of an advanced HCC, also called Barcelona stage C, where they will need some systemic treatment. So what are the characteristics of a patient with advanced liver cancer? Well, clearly patients with metastatic disease or extrahepatic spread. Also, patients can still have disease confined to the liver and be appropriate candidates for systemic treatment. For example, patients who develop macrovascular invasion or on imaging have evidence of tumor invading the liver vasculature, the portal vein or branches of the portal vein. Or patients could still even technically have intermediate stage liver cancer or Barcelona B, undergo chemoembolization several times, but even without developing disease outside the liver or in the vasculature, just become refractory to chemoembolization or local regional therapies. And at that point, it's an appropriate time to transition them to systemic treatments. For the past 10 years, the backbone of management of these patients has been sorafenib. Sorafenib is a multi-kinase inhibitor that targets several important proteins in cancer metabolism and control. These include the VEGF receptor, the RAF protein kinases, platelet-derived growth factor receptor, and others. It was shown in 2007 in the SHARP study that sorafenib improved survival over placebo in a phase 3 study for patients with advanced liver cancer. Importantly, patients enrolled in that study were Child-Pugh A or had well-compensated liver disease because the goal was to improve survival from an anti-cancer drug and to treat patients who have very decompensated liver disease, such as those with Child-Pugh C, elevated bilirubin, ascites. Their risk of death from cirrhosis and liver failure is much greater than their risk of death from cancer, and therefore it would be very hard to improve survival with an anti-cancer drug. Patients like that who have small cancers could be considered for transplant, but again, should they have criteria for an advanced tumor with decompensated disease, it'd be hard to show an improvement. Sorafenib has been shown to improve survival with a hazard ratio of 0.69 or a 31% decrease in the risk of death. Interestingly, it does this without improving response rate significantly. Most of this is achieved by delaying progression. And we've seen over numerous phase 3 studies that sorafenib has repeatedly demonstrated its ability to improve overall survival. And this has been over a decade. There's been numerous studies trying to improve on sorafenib that have generally been unsuccessful. Sorafenib has a well-defined side effect profile that many of us are very familiar with. These include hand-foot skin reaction and GI toxicity, most notably diarrhea. Both of these toxicities can be managed either with supportive care drugs, such as with hand-foot skin syndrome, using urea-based creams and emollients, or in the case of diarrhea, Imodium or other anti-diarrheal agents. Importantly, many patients may require a dose reduction or a break, but importantly, the most important thing I would say is that patients are seen regularly. Even though it's an oral drug, it's not a cytotoxic chemotherapy, but it is an anti-cancer drug, and patients do need to be seen on a regular basis until they're relatively stable. Now, in the past few months, we've had some interesting phase 3 data. In the frontline setting, we saw the results of the REFLECT study, which compared lenvatinib to sorafenib in the frontline setting. Lenvatinib is a small molecule multi-kinase inhibitor that hits the VEGF receptor axis, as well as some kinases that are not covered by sorafenib's profile, such as the fibroblast growth factor receptors 1 through 4. And REFLECT was a large phase 3 open-label study that compared lenvatinib to sorafenib. This was powered to be a non-inferiority study, and it met its endpoint of non-inferiority. That is to say, survival with sorafenib was about 12.3 months, and with lenvatinib, 13.6 months. This difference was not statistically significant. However, the upper limit of the confidence interval for this study was under the non-inferiority boundary, and therefore it was a positive study. Lenvatinib did have an improvement in time to progression, progression-free survival, and actually had a significant higher response rate of about 20% by modified RECIST criteria. Lenvatinib has a similar side effect profile as sorafenib with some differences. Hypertension is a little more frequent and higher grade with lenvatinib as compared to sorafenib, but it does not have as high frequency of hand-foot skin reaction. Other toxicities such as GI toxicity and fatigue are fairly similar. This time, lenvatinib is not approved for hepatocellular carcinoma, but based on the REFLECT study, we suspect that it will eventually get a label as a treatment for first-line liver cancer. Another large unmet need until last year has been what to do for patients in the second line. For the past 10 years, sorafenib was approved in the front line, but for patients where sorafenib was no longer working or did not get a clinical benefit, we did not have any drugs that were proven to improve survival. There were many phase 3 studies, and others are ongoing, but we saw negative studies with kinase inhibitors such as brivinib, the mTOR inhibitor everolimus, and the monoclonal antibody ramucirumab. Interestingly, we saw a positive study, though, with the RESOURCE study, which was published in Lancet in 2017. And this was a study that took patients with documented radiographic progression on sorafenib and randomized them to regorafenib or placebo. Regorafenib is a very potent multi-kinase inhibitor with activity against the VEGF receptor, as well as the Ty2 and other kinases. This study showed an improvement in overall survival with a hazard ratio of about 0.63, or a 37% decrease in the risk of death. Unlike sorafenib, regorafenib does have a higher response rate of about 9 to 10% using modified RECIST criteria. Modified RECIST criteria, remember, takes into account not only the size of the tumor, but the size of the enhancing component in liver tumors. Regorafenib did improve time to progression in PFS, and like sorafenib and other multi-kinase inhibitors, it has a fairly predictable side effect profile, such as hypertension, again, GI toxicity like diarrhea, and hand-foot skin syndrome. Interestingly, in the RESOURCE study, patients were required to tolerate sorafenib for a specified period of time before being enrolled in the study. A recent analysis from the RESOURCE study evaluated the time on drug, evaluated survival from the time of starting sorafenib to death on the resource study. And from this continuum of kinase inhibitors for patients who qualified for the study, so obviously a subpopulation, we saw that survival from start of sorafenib until death on study was about 26 months. That's a very impressive number and will need to be further validated in clinical practice. At this meeting at GI ASCO, later in the meeting, we'll be hearing about another positive study in second-line liver cancer with a kinase inhibitor. This drug, cabozantinib, is a multi-kinase inhibitor that hits the VEGF receptor axis and uniquely also has activity against the hepatocyte growth factor receptor c-Met, as well as AXL. Cabozantinib is currently approved in kidney cancer, and this study, similar to RESOURCE, took patients who progressed on sorafenib, but it also took patients who were intolerant to sorafenib and also took patients who had up to 2 lines of therapy. And the data we have available today indicates that it was a positive study, that overall survival went from about just over 8 months to just over 10 months. This is a hazard ratio of somewhere in the 0.76 range, and there were no new toxicities with this drug in the liver cancer space as compared to other indications. And again, hypertension, some degree of hand-foot skin syndrome, and diarrhea and fatigue being the most common. So as we've discussed now, over the past year and a half, we've seen numerous phase 3 positive studies in the front line with lenvatinib being non-inferior to sorafenib, and now in the second line, regorafenib being first and approved in the second line setting. And at this meeting now, we have data with cabozantinib in the second line setting. This is not even to discuss the monoclonal antibodies that are in development, such as the immuno-oncology agents, nivolumab, which received accelerated approval a few weeks ago based on a single-arm phase 1-2 study in second-line liver cancer. At this meeting, there's also some data with pembrolizumab, but a very exciting time in the liver cancer landscape, and in the coming year, we'll see some additional results of phase 3 studies, and I look forward to discussing those with you in the future. Thank you for your attention.